Welcome to Counterpoint. I'm Tanya Granick-Allen. Healthcare seems to always be a contentious issue between access, funding, quality of care. Many Canadians worry about healthcare. Canadians expect to have reliable and quality healthcare when they need it. But with wait times increasing for specialists, tests, emergency rooms across the country over capacity, many Canadians are worried about the state of the system. And even though COVID seemed to usher in greater ease and access for both patients and doctors with virtual appointments, many doctors are feeling burnt out and underappreciated. And with the recent changes to the doctors' billing system in Ontario, some doctors have now seen that their per-visit fees are slashed when it comes to virtual care. On December 1st, Ontario introduced a number of permanent changes to its virtual care program that would see the fee paid to doctors cut from $37 per patient visit to only $15. So how will patient care be impacted by this change? Is virtual care actually helpful or harmful? What does healthcare delivery look like going forward post-COVID? Well, joining us now to unpack it is Dr. Michael Verbora, who's a practicing physician, chief medical officer with Alafia Health, medical director with Field Trip Health, and an assistant professor of medicine at McMaster University. Thanks for coming on, Dr. Verbora.
Thanks for having me. I appreciate it.
So perhaps you can start by unpacking what were the changes that the Ontario government announced recently?
So the changes predominantly are around the rules for billing for virtual care and then the fees associated with it. And as you highlighted there in the intro, a lot of family doctors who kind of slowly developed more specialized practices, they're probably the most affected because their fees are being slashed by about 70% unless they see patients in person first. And so the real challenge is it's not only just the fee slash, but it's also the amount of bureaucracy that is coming with it. So there's nothing worse as a physician than every contract every 3 years having more and more rules to follow, more ways of having to, contact patients and check who can see them, when they can see them, when you last saw them. So that just creates a ton of inefficiency in an already inefficient healthcare system.
So it sounds like a lot more bureaucracy, and I can't believe you have to redo that every 3 years. That sounds like a lot. So what was previously in place prior to this December 1st renegotiation?
Yeah, so I think you have to look at it from two perspectives. So someone like myself, I've been doing virtual for 7 years, and I started as an early adopter in the Ontario Telenetwork model. And the whole point of that model was to make sure people in rural communities had access to the doctors in Toronto, essentially. Let's call it as such. And then when the pandemic hit, the other 90% of doctors who weren't familiar with virtual started to do virtual just to keep people away from each other, to ideally slow the spread. So those doctors started adopting it, and the government introduced codes that were on par with in-person. So physicians got paid pretty much the same amount as in person or as virtual. Now, the new contract, I think what the government was concerned about is some physicians haven't gone back to the office as fast as they would like. And so I totally understand you need to ensure that physicians are available in person. But there's a number of patients now that are caught in the crosshairs of these new rules. So doctors like myself who've been doing virtual for 7 years, I have patients, I'm in Toronto, and I have patients from Windsor all the way to North Bay. And these patients are actually very, very vulnerable, very, very complex, on numerous medications, have treatment-resistant mental health problems and treatment-resistant epilepsy and other chronic illnesses. The problem with that is now it makes it very, very hard for me to continue to do virtual care for them unless they're willing to come drive 7-8 hours to see me for a 10-minute visit, and I've been seeing them virtually for 7 years. So that's a huge inconvenience for them, and they don't necessarily have the expertise required in their community. So it's an access issue now.
Now, one clarification. So you said that in order to bill at the higher rate, which seems reasonable, one has to see the patient first. Do you mean in person, or do you have to see them once in a year, or what's the requirement?
Yeah, so if you're a family physician doing some type of work outside of certain models, like family health organization models, you have to see your patient in person. And then for the next 2 years, you can continue a virtual relationship, which I think sounds pretty reasonable. Like, we should be seeing people in person. But the problem is if you've already built this virtual practice because the government asked you to help them build this to ensure access for rural patients, it makes it very difficult for them to come down, 5, 7 hour drives just to do a 10-minute visit,
I agree.
only to
I have
be
to
able
pause you
to.
there. We got to cut to commercial. We'll be right back. Welcome back. We're discussing virtual care and how that's being impacted by recent changes to the Ontario system for doctors' billing. And joining me again is Dr. Michael Verbora. Dr. Verbora, before we went to commercial break, we were discussing how billing can impact access and how virtual care and access to virtual appointments actually impacts greater those living in a rural environment. Like myself, for example, I live in the country. We have very few specialists. There's always a desperate need for general practitioners. And I can say I definitely benefited during COVID to be able to access more healthcare virtually. Is that commonplace? If that's been your experience with your practice?
Yeah. So, like, again, I've been doing virtual for 7 years, and the type of practice that I mostly do is counseling. So, it's mostly long conversations about risks and benefits of different types of therapies in conjunction with other medications and altering medicines. I'm not doing a ton of what we call diagnostics. I think when you're doing diagnostics, you have patients with new symptoms and they need a workup. Being in person is definitely the better method. And that's probably from a safety perspective as well. But when you're having conversations, like, for example, mental health mostly or pain management mostly, that can be done virtually. It's very inconvenient for a patient have to drive 4 to 5 hours, lose a day's pay of work just to do, let's say, a 10 or 15-minute visit with a physician. And that's kind of, hits at a bigger issue in healthcare. And I was speaking to a colleague last night who's now leaving to the US because she's an innovator. And the challenge here in Ontario and many other provinces is, like, it's so hard to innovate and provide efficiency in healthcare because the moment you do, the government comes and they start trying to cut your fees or slash your fees for that innovation.
Well, that sounds shameful to me. What you've just expressed, that's terrible. I mean, we should be rewarding those who do innovative things and want to be more efficient with healthcare delivery. And I think that's a good thing. I do agree, though. Yes, as you suggested, for diagnostics, and obviously it's good to have that in-person relationship. Sometimes doctors will catch things that you wouldn't self-diagnose, and that's important because they are specialists. They are trained specially in medicine, so we want that kind of expertise. And like we mentioned before, perhaps for those living in urban centers, this is a completely non-important conversations, but those living outside GTA, this could very well much play into how they receive healthcare going forward. So with yourself, because you've engaged in virtual care for so long, was there no way for you to be grandfathered in, for example?
Well, you'd think that they would try to grandfather people in, and they made exceptions to the addiction medicine for the people who are doing opiate replacement therapy. And there might have been one or two other small exceptions that have been kind of quiet or hush hush. But look, we've advocated through all the proper channels. I sit on the OMA committee for cannabinoid medicine, and I don't know if it's the stigma of cannabinoid medicine or what it was, but our arguments weren't getting through to anybody on the OMA side or the Ministry of Health side. And it's really unfortunate because my practice specifically, I have hundreds of children with pediatric epilepsy and autism. These are very highly sick children, and just if I could prevent just one of them from an ICU visit, like, that makes up more than half the amount of money they're going to pay me for the year. So it's just, again, short-sightedness. I really wish we would just allow and trust physicians and patients to make the best decision for when they should be in person, when they should be virtual. And that's a mutual shared decision that should be taking place. But when the government kind of sticks their nose in and says, sorry, we're going to force this a certain way, it ends up just creating a lot of problems for patients and a lot of problems for physicians.
So some of your patients, as you said, many of them are pediatric, are children. How have their parents responded to these changes?
Yeah, well, some of them are trying to figure out alternative ways. So we're trying to find doctors in their communities that might be able to do this work, but because it's so subspecialized, and I'm getting referrals from pediatric neurologists here in Toronto alone. So it's kind of a very, very subspecialized area of work. It just happens to be that I'm a family doctor. If I was a specialist, I'd be able to do this work virtually. So there's haves and have-nots in the system. So one, they have to either try to find a local doctor, or two, they have to either drive in person, or three, we have to try to accept some of them that are within a certain radius and just eat the 70% pay cut, which we can do the odd one. But you can imagine it's impossible to run an efficient business if you're taking a 70% haircut, your rent is going up, the staff wages are going up, your fees for your electronic medical records are going up, your liability insurance is going up, your college fees are going up. So everything's going in one direction. The only way to keep the businesses running is to find efficiency. And then the government introduces more inefficiency.
My goodness. Well, it sounds like there's a lot of work that needs to be done in this department. Again, I was a great user of virtual healthcare, and even I can make a decision. Oh, I think I should see the doctor in person or not. But sometimes I had the physician saying, "No, you should come in person," and I trust their judgment. I'll say, "Yeah, no problem. Let me know, and I'll drive the 2 hours to Toronto or wherever it might be." So I do think that there is an importance that we must place to let the doctor make that decision. I mean, again, that they're specialists in their trained field after all. We're going to continue this discussion in just a few moments. Welcome back. We're discussing the recent Ontario cuts to virtual healthcare billing and how that might impact you, the consumer or the patient. And joining me again is Dr. Michael Verbora. Dr. Verbora, I think we should push pause on this conversation. You are involved in so many different areas of practice. When I was putting together your bio for the opener for the show, you wear very many different hats. Tell us about some of your unique modalities of practice.
Sure. I'm a family doctor by training, and so I do a little bit of family practice, which is mostly walk-in medicine. It's only really to help the community here because they're in dire needs right now. I also do student health, which is a team-based model with 4 other physicians, and that's at Seneca College, and we treat tens of thousands of patients there. I also do some very innovative stuff. So I work with cannabinoid therapy. I've been doing that for about 7 years. And as discussed, we have very complex patients with chronic illnesses as well as pediatric epilepsy. So we use medical cannabis to help them wean off other medications or stabilize their health conditions. And then I also have a very innovative work in psychedelic assisted therapy, where we're using novel drugs and therapies to help people who have the most resistance to treatment of their mental health with traditional options.
And that's fascinating. And you did mention in our previous segment that you thought there might be some stigma when it comes to cannabinoid therapy with respect to some of these fees getting slashed. Now that recreational cannabis is legalized, but of course medicinal cannabis has been legalized for quite some time before that, why do you think such a stigma still exists? And I guess also folks might want to know, how did you get involved in that kind of therapy delivery?
Yeah, well, I'll start with the second question. I was about to graduate probably, I don't know, 7 or 8 years ago. And I remember about a month or two before I graduated, I said, I don't know how I'm going to graduate and just continue to treat these patients by prescribing more and more medications. And I was at Toronto Western, and these patients are so complex. They're on, 10 to 12 pharmaceuticals. And like, you do not feel like you're doing meaningful work because you're barely moving the needle visit after visit, and it's like banging your head against the wall because patients keep coming in with the same symptoms. And then a couple of patients were saying, "Oh, I started using cannabis, I started getting better," and they started going off their medicines, which was very contradictory to what I was taught in medical school. So I ended up having to investigate myself and see what I could observe. And so I went to a medical cannabis clinic. I worked with patients, and I discovered that maybe a lot of my teaching wasn't accurate and up to date. And so I learned by meeting thousands of patients that, when you use cannabis appropriately, one can palliate numerous symptoms simultaneously. So one medicine might be able to do the same thing that 4 or 5 prescription pills might. And two, you're able to get off of many medications. So this is peak opioid crisis, peak benzo crisis. And so I was using cannabis as a harm reduction tool to get people off of the drugs that could kill them.
My goodness. And again, you mentioned that you deal with very complex pediatric cases, highly autistic children, those going through, I think you even said through cancer?
Yeah, three main populations: autism with severe behavior issues, treatment-resistant epilepsy, so seizure disorders, and then pediatric cancers, so oncology.
My goodness. And again, with these new changes, these patients will have their care limited because, I mean, your fees have been slashed.
Yeah, we're going to do our best to try to help them navigate and try to find other doctors in certain communities. We're going to ask as many of them to come in person as we can. But yeah, these are really sick children who already have, half a dozen other physicians who are also being able to do virtual. So there's a lot of haves and haves nots. Some of us are able to do virtual. Some of us have to follow all these rules. And the other point is like we share and we do work in teams. And that's the other problem that this doesn't address. So even if someone comes in person to see me, if I'm on vacation for a week, or if I'm out of town, or if I have a doctor's appointment and there's an emergency, One of my colleagues can't just see them and step in and help, which we've been doing that for 7 years. That's how we've been trained to
Right.
practice medicine, is in teams. So they would have to come back in person for a separate visit with another doctor just to establish a new relationship with that doctor so that they could continue virtual.
And
So it's just
and
really short-sighted.
and why couldn't that team cover that patient? Is just with the new regulations, it's just simply verboten?
Well, again, it would be a 70% fee cut. So they'd have to step in, and it's going to take you 2 times as long to 3 times as long to understand that patient's needs because they may not be your own. So you're doing 2 to 3 times the amount of work for a 70% pay cut.
Right.
And so it's just not sustainable. So physicians will just say, look, I want that person to come in and see me in person because then I can build the appropriate code and do the appropriate amount of work for the amount of money that's reimbursed. So it's impossible to run a practice. It's impossible to probably run any business if you lose 70% of your revenue, right?
Do you feel that many doctors may just throw in the towel and say, I've had enough of this, and go elsewhere, go to the United States?
Of course. Yeah. And I think it's not just the money. It's important to note that it's not the money, but it's really the bureaucracy. And the bureaucracy creates more work for us. And more work for us away from patients is what is the single most frustrating thing. I'll take a pay cut if you cut the bureaucracy out. That's the truth. So I'm doing triple the amount of documentation just to be able to see my patients. That's gone up massively.
Okay, we're going to
So,
pick this
I
up
was
in just a moment. We've got to cut to commercial. We'll be right back. Welcome back. We're wrapping up our discussion on the new cuts to virtual care medicine practice here in Ontario. And joining me again is Dr. Michael Verbora. Dr. Verbora, thanks again for coming on. Not only do I appreciate your perspective and obviously your very unique practice helping so many thousands of patients across the country, across the province rather, you really helped us unpack a lot. And before we went to commercial break, you were really highlighting the level and the pure volume of paperwork and bureaucracy that doctors go through. And a lot of us on the consumer end, a lot of us patients don't recognize that once we leave that doctor's office from that visit, there's a lot of paperwork that goes on in the back end. How does that harm or hinder delivery of medicine for doctors?
It's horrible. I've never seen it worse than it is now. And I'm married to a family doctor who does primary care. And I've watched over the last 7 years, 8 years, as her practice has gone from 1 or 2 hours after work of paperwork to about 4 to 6 and like never catching up. And so people like patients don't realize that for every hour in person that a doctor's spending with you, there's a minimum of 30 minutes of paperwork that needs to be done. And it just drains your soul. Like it just sucks the energy out of you. And it just becomes so defeating because you're not in medicine to do paperwork. You're in medicine to be patient centered and patient focused and to be spending your time with them.
Right. And I can see, and we've touched about this before commercial break, that some doctors are saying, we've had enough, we're leaving.
Yeah. One of my colleagues, we just spoke last night. She's a very innovative person, developed EMRs and technologies, and her business is being drastically affected by the healthcare changes. And so she's opted to move to California, where she feels like she'll have more freedom to innovate and run a more efficient practice without so much red tape. And again, it's not really about the money, it's about the amount of steps and bureaucracy and paperwork that they have to go through to see a patient.
Well, and we don't want to be a province where we're chasing away excellent talent, especially ones in which we've invested so much money. You went to an Ontario medical school, and I know the government does, I believe, subsidize medical education for students. We've invested all this time, energy, training, and just to have someone up and leave because of the way we manage or mismanage the system is quite shocking.
Yeah, it's quite unfortunate. And right now the big issue is really in family medicine, where we need, a huge amount of new doctors coming into the system. And if you look at the universities and schools, everybody who's in family medicine is choosing to do specialties a year later, into palliative care or into pain medicine because they don't want to do primary care because of the bureaucracy. That's the number one reason why they won't do it. So not
Wow.
only are we in a crisis now, we're going to have a bigger crisis in 5 to 10 years.
So how do we solve this? Do we simply graduate more doctors? I know we have caps in Canadian medical schools. What do you feel would be the solution to the pending problem?
Yeah, I take a very holistic approach. So good primary care is, a pound of cure is worth, $1 million. So a pound of prevention is worth more than a cure. So we really need to invest in prevention, and that means listening to family doctors in the front line and finding out the pain points. So we would love help with our bureaucracy. We would love help with our paperwork. We would love other people to be able to do paperwork. I get requests from social workers, psychologists, from teachers, from principals. sign this, do this paperwork, write this letter. We need to give more people authority to manage some of these issues rather than just the family doctor. Two, I'd love to work in a team where I have nurse practitioners or international medical graduates, but right now I can't bill for their work. So I'd have to pay them and not be able to generate any revenue. So it's impossible to work in allied team approaches. And then that brings up the bigger point is that some doctors can work in teams where they have access to other professionals, and doctors like me working at walk-in clinics, I don't have a therapist, I don't have a social worker, so I have to take on those roles as well.
So how does one better your situation, for example? How come some have these teams and others don't?
Yeah, well, the government keeps changing their mind about different group models. So they allowed us to do what's called family health organizations, where you roster patients, and then they would give you some resources for psychotherapists, pharmacists, etc. But again, that's hit or miss. Some people get it, some people don't. But then they cut that off. They said, nope, no more doctors can do that. And then this new contract, they said, okay, you can come back, but we also made all these rule changes, which also make it unattractive again. So it's this cat and mouse game. Like you can't figure out what you're trying to do as a family doctor in this system. It's just too challenging and changes too quickly to be sustainable.
Right, and again, people want that primary care, they want that family doctor and access to them. I don't even think people would opt for virtual care if they had a quality physician in their community, especially those in rural Ontario. Wow, this sounds like it's a lot to digest, and I guess we're going to have to see what happens going forward. But thank you so much for your time, Dr. Verbora, and all the best to you in your practice.
Thank you. Appreciate it.
Well, we started this show discussing virtual versus in-person care, and we've had a very wholesome and holistic discussion on the benefits of both, but more than that, on apparently how bureaucracy is really bogging down a lot of doctors in our Ontario system. That's got to change. For Counterpoint, I'm Tanya Granick-Allen.